this is the part here. This is a very long session, but extremely important. And we really appreciate our listeners who have stayed with us for this duration. We're almost at the 3 hour mark. But I think that what we're going to find is that the work that has been done through the coalition, especially highlighting what Valentina and Joachim has been doing at pulling these speakers together, this is going to form a resource that is going to train people, I think, for years to come. It is so far ahead in terms of the thinking and the research. And so it will take some time for people to catch on to just how significant this is, but I believe that it will happen at some time. So I think this is a time for us to just talk for a little bit before we would close out our session. And I've had the pleasure of listening to everybody. And can I ask a question? So, one of the questions I want to ask is long COVID random, or does it affect specific people? Now, this is an extremely important question to me because a lot of people think it's just random. If it's just random, we cannot predict who may be at risk. We cannot do anything preventative. We cannot do anything, so to speak, in case they get infected. So from my perspective, from a clinical point of view, as with many other diseases, we identify risk factors, we manage risk, we reduce the risk of long COVID. Does anyone have any thoughts about what are the characteristics of people who may be at risk?
Well,
oh no, you are okay, Leo. You weren't muted.
okay. There are a number of studies that have attempted to answer that question. Here's the big problem with that. I think we know a lot about the pathophysiology that leads to long COVID. I think that there are elements in that pathophysiology that can be the target for therapeutic interventions at the time of acute COVID or before. And I have a protocol that I call long COVID prevention that I use with my patients based on that. I've seen people who were really, people who've come in to consult me, they were really healthy, they had great diets, they were athletes, they had no illness, and COVID left them, and they didn't even necessarily have severe COVID. COVID left them just devastated. And sometimes it wasn't immediately after COVID. They seemed to recover, and then something else happened, and then they crashed. So even though statistically we can identify who's at greatest risk, people who are overweight, women over the age of 50, people with a history of asthma, those with low levels of IgG3 or IgM. These have all been reported in different studies. There are people who have none of those risk factors, who really have their lives transformed by this condition. My view on this pathophysiology is that depletion of ACE2 and mitochondrial damage are key factors from which a lot of the other pathologic events emerge. And so what I do in treating patients with acute COVID is I try to follow their symptoms very closely. And if I don't see that, and I use treatments that have as their goal enhancing ACE2 activity and supporting mitochondrial function. And I use that at the time when they're ill. I would say that in my practice, the incidence of long COVID is somewhere less than 2%, not anything like the statistics that are routinely reported. So that's my perspective on prevention. the I want to say one thing about the amyloid and about the unfolding protein, the misfolded protein response that Stephanie talked about, which I think is so important. That may be happening primarily in the brain. And that is scary because how do you get in there? There is evidence from Parkinson's disease that it could start in the gut. And what's encouraging about that is maybe we can really get in there and do something about that much more easily. This is research from Rush University, and there have been several other centers, but specifically the work from Rush University in Chicago, where they looked at people with early Parkinson's disease and they looked at gastrointestinal function. And most people with Parkinson's disease have GI symptoms before they develop Parkinson's disease. What they found was inflammation in the colon with increased colonic permeability, not anywhere else in the gut, just in the large intestine, and the formation at sites of inflammation in the colon of alpha-synuclein. That it appeared the alpha-synuclein was traveling from the colon into the central nervous system along the track of the vagus nerve and maybe other enteric afferents to the brain. So I do think that, I was, a year and a half ago, I was pretty skeptical that the gut was going to be a key battleground for COVID-19 or long COVID, even though my background is in dealing with the microbiome. But the evidence that keeps accumulating has led me to believe that I should have seen that.
Can I say one thing on that before
Sure.
the thing that stood out to me was the research paper showing that 40% of patients who had inflammatory bowel disease ended up with long COVID. That to me indicates a very serious risk factor. The other one that I would look out for is interferon autoantibodies.
Right, that's definitely associated with mortality and severe acute COVID. I had seen a paper which found that there was a negative correlation between spike protein antibodies and the development of autoantibodies. That somehow, so the theory was that the autoantibody formation was interfering with neutralizing antibodies being formed. I do think that autoantibodies play a major role. Are they occurring because of the T cell dysfunction, or is there some other driver? And just to take this further, and I think this is an area that really needs to be explored. Two things about antibody synthesis in the course of COVID-19. And I'm sorry that this is so complicated. There's a study from the University of Arkansas that found that the majority of people with acute COVID had developed autoantibodies against ACE2 that persisted after recovery. These were functional. So this might explain the ACE2 damage that occurs in people who who aren't very sick to begin with. But they found that these autoantibodies, the timing of these was very much related to the development of spike protein antibodies. And what they postulated is that there is something called an immune network that forms, that is the antibodies to the spike protein are generating antibodies against the antibodies. They're called idiotypic antibodies. And then there are antibodies generated towards those called anti-idiotypic antibodies. And that the anti-idiotypic antibodies were actually the autoantibodies to ACE2. So there's a lot of complexity. I've approached immunologists about, well, what can we do about that? I haven't gotten any answers. I have tried proteolytic enzymes as a way of trying to break up these antigen antibody complexes that are forming, which is what these immune immune networks are. One other study that I think is really important. It was a study that looked at one of the mysteries of the early part of the pandemic was that people would get sick. They would seem to not be so sick for the first week, and then suddenly at about day 7 or 8, they would just crash and develop a cytokine storm. And there was a South African physician actually who claims that by giving people steroids on day 8, he saved everybody. So there is this fascinating study that was published about a month ago. ACE2 is not the only cellular receptor for SARS-CoV-2. There are other receptors that have been identified. Monocytes are white blood cells that do not have ACE2. Yet Patterson in his work found spike protein in senescent monocytes. He thought it's because they were gobbling up the endothelial cells where the virus was. It turns out that there is a protein on the surface of the spike of monocytes, atypical monocytes, called CD16. And that is a receptor for the spike protein. The virus can enter cells that express CD16 on their surface, and aged monocytes, non-classical monocytes, senescent monocytes express CD16 on their surface. They do that under the influence of various inflammatory chemicals, in particular something called fractalkine, which is associated with coronary artery disease. It may be one of the reasons why people who have coronary artery disease are at greater risk for severe outcomes, because they have more of these monocytes. Once the protein enters the monocyte, it induces a state of pyroptosis. That is, basically the monocyte bursts into flame, in essence, microscopically, and initiates the cytokine storm. The timing of that corresponded to the development of antibodies to the spike protein, suggesting a phenomenon that had been feared and which has been described in things like dengue fever or Zika virus, called antibody-dependent enhancement. Interestingly, this only happened with natural antibodies. It didn't happen with vaccine-induced antibodies, which is, that's what most of us were afraid of, that the vaccines would induce this. In fact, the natural infection was able to do this. So, there's something in the antibody response to this virus that is part of why people are getting so sick. And it's very likely that it may be part of the long COVID phenomenon. I view, and I'm sorry for going on and on like this. I can get kind of worked up about this, and I haven't come up with all the answers, but I do think that balancing and getting the proper T cell immunity is really going to be the solution, the long-term solution.
Yeah, go ahead, Georgia. You're muted at the moment.
Sorry about that. Yeah, thank you, Leo. I think there's one thing that was in the slides for the preparation of this conference, which I included, but we didn't find that anywhere with the speakers, that the T lymphocytes are being directly infected. And there's even a picture under the electron microscope where you can see the T lymphocytes filled up with SARS-CoV-2 virons, as we could also see with the bacteria. But maybe for us to Philip's question, what could be the underlying factor of why people do get long COVID? That is a question Winston Churchill once said when he was listening to all his generals. He said, like, oh, now I have the sum of all fears. So if you go just onto our pathway list that we have, which is now around more than 200 single pathways, which are kind of self-perpetuating and fueling each other, and in an awesome interplay. That sometimes when we are looking at all these studies over the last few months, it was like we were concluding, what is this? I mean, Stephanie has gone through the glyphosate molecule for, I think like around 8 years, and has published, I don't know how many different pathways to disease. That's even the name of your paper. And I'm so grateful that you've been my teacher before COVID came, because that is exactly the point. It's a fantastic construct, this spike protein and this virus by itself. I don't know how that came about, but I'm in awe as to the sophistication of what it can cause in self-perpetuating and self-fueling destructive cycles. Compared to that, glyphosate is almost a nutraceutical, as I have to say. So the question, who's going to get long COVID or not? I mean, if you have a dysbiosis and you're preconditioned, it's like an old building. If an earthquake hits, then a building that is unstable will crumble first. I mean, that's in the nature of the thing. But by which way you will crumble, there is hundreds of ways how this COVID virus can get to you and what it can trigger, and it depends where it comes in. And like I said, it can infect your T lymphocytes directly. It can infect your cardiac pacemaker cells. It can go into your brain. It can go anywhere. It just depends a little bit. Plus all the variants, you were talking about host cell receptors. We have been trying to cover, and I think we do successfully cover, more than 12 different host cell receptors, apart from ACE2. So that was in the early research. We covered everything from CD147 to DPP4, and all the other ones known that are from other coronaviruses or previous coronaviruses like MERS, SARS-1, and also the so-called flu coronaviruses, plus covering another, I think, 12 or 14 different enzymes, cleavage enzymes that the spike protein or the virus needs for fusion or endocytosis, etc. So that is all possible, but you have to have early patient treatment. So what we are looking at here is the damage already being done, a patient not being treated early on, and then having these symptoms. So in my opinion, it is very much possible that a very healthy person gets infected with SARS-CoV-2, and it just hits his T lymphocytes, and then he gets immunodeficient in a way, and then he upregulates bacterial co-infection, gets dysbiosis, and you just name it. So it can come in through every crack, and it will break open every crack it finds. It's a very detrimental molecule.
Go ahead, Abdul. You're muted.
We actually come across this question in our Long COVID Congress and Foundation each time we debate any other topic or a discipline. The answer to this possibly lies in the type of the immune response a person actually mounts. And we are genetically programmed to mount a particular type of immune response to a fixed dose of viral load, So if we mount a moderate response to clear the virus, okay, we won't go to long COVID. If the response was subtle, it partially cleared it, virus remains, goes to hideouts, comes back again, okay, residual virus, residual protein, okay, long COVID. So a suggestion was that, and I published on this one, and somebody like universities in in UK and US are following that line, that it's the HLA antigen of what we are made up of that determines the type of the immune response we will mount. If we completely eradicate it, okay, no question of long COVID. I mean, like even it could do it in the gut, it could do it in the sinuses, it could do it in the tonsils, everywhere. If you are unable to completely eradicate it, then it remains okay, and then it shows off. So that HLA someday possibly, in my opinion, would answer the question that a particular subset of types of HLA antigen could possibly predispose towards long COVID. My take on it.
Yeah, I'll tell you what, and this is my challenge always. I say categorically, if we do not figure out exactly the pathophysiology in long COVID, we will go in a circle. We have to find the fundamental pathophysiology. And here's another thing that I strongly believe. There is nothing that is new. Everything we see has happened before. The challenge is to find the parallel disease. So far, and I think I'm getting closer to it, the parallel disease to long COVID is Epstein-Barr. Epstein-Barr, however, does B cells. It seems as though SARS-CoV-2 does T cells. but it is going to be a parallel disease, and we have to figure out. The problem we've got is we haven't properly figured out Epstein-Barr either. Long Epstein-Barr. People have it for years after infectious mononucleosis, and we manage them as chronic fatigue and whatever else. So the challenge that exists for us today is that in order to solve long COVID, we have to be willing to solve all those diseases that we have ignored for the past 20 or 30 years.
I agree. Yeah, you're right.
May I say one more thing? Today we have the conference was actually split in two different topics. One was the first part, looking more at the more like the chemical disbalances, like the neurotransmitters and the NAD plus and mitochondrial mechanisms. And the second part was actually addressing something else that is not really playing out yet, not in large numbers. And so, apart from curing long COVID, actually the idea of us to have the second part of that conference is as a warning. And like Stephanie has been warning for 10 years about what glyphosate will do in Alzheimer's, autoimmune disease, and autism, and you just name it. This SARS-CoV-2 will be worse. And yes, Epstein-Barr will contribute, and other pathogenic overgrowths as well. And we could name another 50 that play a role and that are all upregulated, like Lyme, like fungal diseases, like just normal bacterial co-infections, biofilms that are settling because of pathogenic overgrowth, and that will be the breeding ground for amyloid formation, and so on. It's like I said, it's an intricate, awesome mechanism that we are facing here. And what we want to say, without creating any panic, look, what can we do when once these are manifested diseases? If you have Parkinson, if you have multiple sclerosis, if you have dementia and Alzheimer's, it's going to be much harder to do anything about it. So why we do this is to say, look, let's look at that and find more proof, and let us see how we can prevent it from happening. And maybe the people that are facing long COVID right now are more prone to long-term neurodegenerative disease than people that have no problems right now, which doesn't exclude that they might get some trouble with prions or whatever is in the forming. And that is the idea.
Yeah. Can I ask Stephanie a question? There's something that you said today that I had only come across recently that really worried me. I didn't know a lot about exosomes.
Yes.
Now, what is technically the difference between an exosome and a lipid nanoparticle? Are they not technically the same thing? It's just that all cells produce exosomes. So it's such an important question in my mind, because if any part of the virus, or potentially even the vaccine, we still have to explain long vaccine, could that then become packaged in an exosome and shared?
That's what I think is happening. I think that exosomes, so you're right, they are lipid particles. They're small particles. You have LDL particles that are also lipid particles, and they're very different. But the exosomes, it's increasingly becoming clear to a lot of researchers that the exosomes are maybe the primary communication network among the cells. And when a cell is stressed, it basically dumps its load into the exosomes and ships them out. And it's partly because it's not able to turn it into a lysosome and digest it and break it down. So it has these toxic exposures that it can't clear. And it's in the endosome. And then the endosome is like, my gosh, what am I going to do with this stuff? I can't clear it. So it says, okay, I'll just pitch it, just throw it out there and let somebody else deal with it. I think it's a way that for a particular cell to sort of temporarily solve its problem by just giving it to somebody else. And then these exosomes travel very nicely along nerve fibers. And this is the whole thing with Parkinson's disease. I knew about this before COVID because I've studied Parkinson's pretty heavily. And I was aware that it starts in the gut, and you have these immune cells that take up these, prion-like cells that are produced by pathogens, and they carry it into the spleen. They take it into and then they release these exosomes both from the gut, the gut's immune, the gut's immune system, and also from the spleen. They release it into the circulation, and it travels along the nerve fibers. And those nerve fibers make a very beeline for the brain, and you go right into the brain centers, even the ones that control breathing and heart rate and consciousness. Those can get hit hard. I think we're finding people, I suspect, issues with even just getting the parts of the brain that are really critical for main function of the body to keep it alive can get inflamed and to the point of even killing the patient. So I think it's really scary to think about these exosomes and their ability to travel throughout the body along the nerve fibers.
I'll tell you what, is that I'm going to make a prediction here, and I'm trying not to be too dramatic with the prediction, but there's something that has been floating in my head recently. It is that I suspect that we're going to see a lot more spontaneous brain bleeds because of that amyloid. It's what we call cerebral amyloid angiopathy. And it's a predisposition for hemorrhagic strokes. If what we are saying is accurate, what we should start to see an uptick of is that we are seeing an increased frequency of hemorrhagic spontaneous strokes. And if that's the case, that is a very big worry and something. This is part of the reason why we need to get a handle on this very quickly, and we need to identify who is at risk. This is why I'm emphasizing this so much. Go ahead, Joachim.
Great. If you want to do something quickly now, we were talking about these three components that would lead to these clottings and to this thrombi and so on. So the neutrophil, the control of the neutrophil activation is the key point. Bring down neutrophil elastase, and then you have taken out one of the major components that can fuel this process.
Yes, I understand. But I think even so, I guess part of the reason I'm asking these questions is because so much of medicine is about predictive work, meaning that we know that if you have hypertension, you're at risk of heart disease. So we therefore manage your hypertension 5 to 10 years before to reduce your risk of heart disease. We don't want to treat the fact that you've got a heart attack. That's what we used to do. And so medicine always requires a degree of predictability as to risk. And this is what I'm saying is that we're missing at the moment. We need to know the risks. We need to preempt the patients who are at risk. We need to be able to intervene easily years before this happens. And so the big part of the challenge is, how are we going to do that?
Listen to Rachel and Leo, and do everything you can in your food, in your diet. Avoid toxins, eat well, and sleep well, and drink clean water, and eat good food, organic. Stay away from glyphosate, etc. Bring all the possible, the chances in your favor and not in your disfavor to start with. That's the easiest. Doesn't cost much.
And I think we already have 200 million people globally who need treatment. So we already have a lot of people to treat. And I think it's best to identify the solutions and apply these solutions already and prevent this mass of people growing further. I think that's my point. And I would like also ask Dr. Shankara Chetty, maybe you can share your experience on tackling COVID.
Yeah, Valentina, I think that with the numerous mechanisms at play, treatment of long COVID is going to have to be individualized. We know about the immune dysregulation that occurs a week after the start of the acute illness, and that seemed to have a genetic predisposition. We know about the infection of the gut microbiome, so that will play into it, and there's a diversity of different gut microbiomes in different individuals, which will increase their propensity of developing infection in those bacteria. There's also the toxin production in the gut itself, with neurotoxins, chronotoxins, and the like, that need to be addressed as well. So I think each patient will have to be examined individually, and we'll have to try and find out the different mechanisms at play for individual patients and individualize their therapy. But I think the conferences that we've been holding are vitally important in understanding the different mechanisms at play. And so we can examine patients and figure out exactly what's at play with each individual patient and figure out a treatment strategy for them. And I think that's what's most important.
Thank you. I think we're coming close to wrap up, but I wanted to ask Rachel a question. And this is something that I've been wondering about. When we talk about fecal microbiome changes in long COVID, what's very interesting is that you have fecal microbiome changes in celiac disease, in fibromyalgia, in chronic fatigue syndrome. Are the fecal microbiome changes that we're seeing in long COVID present already, or is it because of the infection?
And I remember we've spoken about this before, haven't we? And the problem is when I get clients coming to me, they are already in the long COVID phase. So when I'm doing gut microbiome testing, I'm only getting a snapshot of what's happening at that particular moment in time. So I don't have any kind of pre-issues. But there is one specific client that I did have that did actually come to me years ago for small intestinal bacterial overgrowth. And we kind of treated her and she went off on her merry way. And then she had a really perfect kind of microbiome, so to speak. But she came back to me with long COVID. And so I've got the comparison of the kind of I've got 3 tests actually for her. So it was really interesting to see that she had low butyrate producing bacteria that had contributed to her SIBO, and she had low lactobacillus and she had low bifidobacterium. So she didn't have anything specifically pathogenic in her gut. She had a tiny little bit of Clostridia, but nothing too horrendous. And then we got her microbiome back up to kind of what is a normal microbiome, but we got her symptom free. And then when she came back into clinic, those exact same markers had come back down. So is that due to COVID-19? I don't know. But, that's the only correlation that I've got. That's the only one person I have with pre kind of COVID gut microbiome. So from my perspective, when I'm doing these tests on my clients, there's not really anything. There's not really any significant gram-negative bacteria going on. There's no significant destruction to the gut wall, so to speak. It's mainly these commensals that are being kind of targeted, and these butyrate-producing bacteria. That's the major correlation I can see in my clinic at the moment.
I'd like to speak up on that because in my book, I talked about glyphosate in the gut. That's a chapter in my book on glyphosate. And I showed that glyphosate has been shown to cause an increase in the pH of the gut, of the colon. The pH becomes too high. And with a low pH is what you need to make both butyrate and acetate. So those short-chain fatty acids, the microbes that make those short-chain fatty acids become depleted because the environment is too basic. There's not enough acid in the environment because of the glyphosate. A very nice study showed both a correlation between the glyphosate levels in the gut in these mice and the levels of acetate production and the pH. So all of that worked perfectly with statistically strongly significant correlations between glyphosate levels and pH and acetate production. And butyrate also needs a low pH in order. Those microbes need a low pH. So I think there's a critical aspect here of glyphosate exposure causing disruption of the microbes that make those short chain fatty acids.
Yeah, I agree completely with you. And even here in the UK, a lot of the kind of nasty pesticides have been banned, but there's still residue around everywhere, and we're still using toxic herbicides and pesticides. And I think, glyphosates are a really big problem. I completely agree.
Listen, I think this was a phenomenal discussion. I really appreciate all the speakers. And I have to say a very big thank you to Kamal. What time is it there now in Australia, Kamal?
It's 7:17.
So he has been with us
You
since
can
about
see the sun
4.
is just coming out. It's really a winter
So
morning.
we really, really appreciate that, Kamal. That has been a
Well, that's okay. It's
tremendous
a pleasure. It's indeed a pleasure for me listening to such an excellent speakers and learning more about neuro and COVID and long COVID. This is really a great platform, and it was great talks. Really great.
wonderful. Thank you very much. And again, I say a special thank you to Joachim and Valentina, part of the Long COVID Coalition, who has got these speakers together. Long may your work continue. It will be appreciated many years down the line, finding all these people to focus their research attention on long COVID. And I'm sure the patients appreciate it. So any final words from Valentina or Joachim as we close out?
Maybe just short. Thank you everybody for all your incredible effort and taking the time and your expertise. And I hope that we meet again in a month's time for hopefully a little bit more positive topics. And yeah, thank you so much for participating, and in the name of the Long COVID Coalition, all the patients and everybody in the industry. Great job. Thank you so much.
Valentina? Yeah.
Thank you very much. And without all of you, these congresses wouldn't be real success. So the knowledge that you bring, the clinical expertise that you bring only fuels our interest into identifying critical causes of long COVID. So thank you for participating. And just maybe only one thing is to, there are some patients who try to ask their own medical doctors to apply one or another treatment based on all this knowledge that is available. And for some reason, doctors dismiss them and they say that I don't have time to read this new research. I've got our own stuff to do. So you as doctors, could you please advise what is the best approach to help patients to get to these doctors and maybe somehow collaboratively generate something that majority of long COVID doctors would look into this research and properly treat patients, not dismiss that we discuss for 4 weeks now, and we still have lots of information to discuss in the future. But we need your advice as doctors as to how we can more widely to communicate that information to those who treat long COVID. What patients can do to support that?
This is a big question, Valentina. And here is I'm going to be honest with you with the answer. In reality, long COVID is a reflection of what we have done with fibromyalgia, chronic fatigue syndrome, post-Lyme disease, and Epstein-Barr virus. And the reality is that medicine has turned its back on it because it didn't figure it out. What we have here is a situation where the patients have got to insist. It's going to be a fight because the history is that if we don't understand it, we walk away. And that's the truth. If the doctors don't have a clear protocol in their mind, a clear understanding of the science, they will walk away. And this is why I've been so focused on trying to find primary pathophysiology, because if it can't be explained to them in a way that makes sense, where the treatments are reasonable and safe, they will not do it. That's a huge challenge. Yes, go ahead, Abdul.
I managed to talk to 7 or 8 of those physicians, and the patients, while visiting them, made a direct call with his consent of the physician that if you would like to have a few words. I mean, like, not everybody accepts that. Okay, some guys have ego issues, but those 7 to whom I talked, they actually were very, eager to listen to what I was saying about them, that the patient is suffering, and some of them nodded. I mean, like, I was amazed. I mean, like, they would hear, but then, as you said, you have to insist. If you don't, okay, they do their casual job, okay, and then they walk away.
We know a lot about the pathophysiology of long COVID. I mean, there's still major gaps, but what we need to start developing training programs for physicians.
Yeah, absolutely.
Based on what is known.
Yeah. Wonderful. Thank you
So
all. Go ahead.
Leo, just to add on that, in Australia in particularly, there are long COVID clinics now specifically, and they are specifically managing those patients, and they're maintaining in such a way so that if something work on certain patients and a similar case can be observed in future, those things can be applied to that. So most of these states in Australia now, they are having a specific long COVID clinics.
That's brilliant.
That's wonderful. Wonderful. Again, thank you all very much. Wonderful to have you all. Tremendous. I absolutely love these, and we learned so much. So thank you for our audience for staying with us, and look out for our next coalition conference, hopefully coming up in about a month's time. Have a great evening.
Thank you so much. This is wonderful.
Thank you to everyone.
Nice weekend. Thank you.